For those of you who don't know me, I'm Jo, one of the managers here at Cork, and hosting with me today is David White, our trustee, and our wonderful volunteer, Pat Spallone. We're going to get straight on with the talk. So it gives me great pleasure to introduce Mr. Daniel Walsh, who's the consultant neurosurgeon at King's College Hospital in London. And yeah, I'll hand over to you, Daniel. Thank you.
Thank you, Joanne, and David and Pat. Thank you all very much for sharing your Saturday morning if you're in the same time zone as me. Um, I just thought I would begin with a little preamble. Why on earth am I sitting here giving this talk? Well, I suppose my qualification for the role is I'm a what's called a neurovascular surgeon. You can think of that as a sort of extreme plumber. I'm one of the doctors who deals with blood vessel structural issues within the brain. So when one is called upon to fix that, practically speaking, I'm one of those people. I've been in consultant practice in London for about 15 years, and focused entirely on issues related to brain hemorrhage, different types of vascular malformations within the brain and spinal cord, including, of course, cavernomas. Um, I advise a number of bodies in different capacities, but pertinent to this talk would be NHS Specialised Commissioning, where I have been their national clinical lead in an attempt to optimize the pathway for patients suffering brain hemorrhages of various sorts, including from cavernomas acutely. And I also advise about low volume yet high complexity vascular surgery and how we regulate and deliver those services in a consistent and reasonably safe way. Last but by no means least, as you will see from my background, I am the local principal investigator for the CARE study, which some of you may have heard of, and if not, will have heard of by the end of my talk this morning, which is an effort to improve the evidence base for which people like me and plumbers like me can refer to make good decisions for people who have cavernomas about their treatment, and also equally importantly, when not to treat. This talk is by request going to be brief. It's not that I'm lazy, but that's what you've fed back to the organization. And I am very much relying on you to have brought along some questions. I'm assured you have, so that we can have a sort of more conversational arrangement rather than me standing giving a lecture. But I'm just going to do a little bit about the basics of what constitutes bleeding. It might seem trivial to understand the difference between bleeding and no bleeding, but you'll see it's quite a knotty question in neurosurgery. It will, as I said, be mostly about your questions. You can ask me literally anything. This is a bit without a net for me, so please bear in mind I don't know everything, and it will, therefore the answers may not be perfect, but I'll do my best. So, I was asked what is a stroke. We use the term stroke quite a lot, and many of you will have been presented with that diagnosis after a symptomatic event, yet wonder where it really fits into the rest of your life. Term stroke is a rather catch-all term, and it's been in use for literally millennia. The chap on your screen at the moment is Hippocrates II of Kos. And about 2,500 years ago, he is credited with the first systematic description of what we would now recognize as stroke. And he was credited, although the term may have been in use long before him in truth, but he's credited with introducing the term apoplexy, which literally meant to be struck down with violence. And he used that term to describe this condition that physicians were encountering where people suddenly collapsed. You see from his own words there, a translation. Suddenly a healthy person seized with head pain. Immediately the voice fails. He snores. The mouth is open, gapes. And if someone calls or moves, he only groans. Nothing with meaning, gives copious urine and does not perceive. So he's just could be describing there somebody who's having an event in their speech part of the brain, in their brain stem. He may be describing, when he talks about the urine, the increased activity in the kidneys that's sometimes brought about by neurochemical changes in the brain. If a fever does not supervene, he dies within 7 days. Um, if fever comes, he used to believe that the health was generally spared. Of course, we know that a little bit differently these days. And he commented that it was impossible to remove a strong attack of apoplexy. It was an irreversible event. So the term apoplexy entered the vernacular, and went through generations upon generations of famous physicians. Here's another very famous one called Galen, another Greco-Roman physician. And he began to recognize and distinguish apoplexies that affected different parts of the brain, and appreciated the difference and the prognosis of, for example, suffering an event in the brainstem in comparison to suffering an event in some other part of the brain that was less critical to the vital bodily functions such as breathing. I was going to tell an anecdote about one of my patients, and then suddenly I thought perhaps I will be breaching confidentiality, so I'm just going to have to drop hints. But I do have a patient who has a condition that predisposes to brain hemorrhage. It may or may not be a cavernoma, but they have a phenomenal record of their family history that goes way, way back to one of the great English families. I won't name the family, but if you go back to Wolf Hall and then go back a little bit further, you're in the ballpark. And peppered throughout that sort of family tree, when you have that level of detail, you can find the term apoplexy from time to time. And it occurred to me that some of you might be interested in genealogy or maintain your family trees. Have a look for that term in it affecting individual members, because that might point to the history of things like epilepsy, brain hemorrhage, or indeed cavernoma. But the modern term stroke refers to, again, it is a catch-all term, and it refers to an event occurring in the circulation of the brain that results in the death of brain cells. Now, there are broadly two categories. There are the type of event where the blood vessels become blocked, depriving those nerve cells of oxygen and nutrition, and over a relatively short period of time, those nerve cells will begin to die. Now, it has become increasingly important to recognize that type of stroke because Hippocrates would be fascinated to learn, have begun to develop treatments that might in fact mean it is not irreversible, and that the process of cell death takes a certain amount of time. And if one can re-establish blood flow to the brain during that time, it is possible to mitigate many of the effects of the number of cells being hurt. So this is a huge development in just the last few years called mechanical thrombectomy. Unfortunately, it doesn't apply to cavernoma type strokes, which are in the next category we'll talk about, but it is transforming the outlook for people who present with these blocked arteries. The other type of stroke might be referred to a bleeding stroke. In this case, the plumbing within the brain is structurally embarrassed in some way and gives way. The amount of bleeding really has a little less to do with the amount of damage that results than it would otherwise in the body, because relatively small amounts of blood can cause the pressure inside the closed box that houses one's brain to rise very, very suddenly, and enough to arrest the rest of the blood flow to help otherwise unaffected parts of the brain. The bleeding itself can physically destroy cells as it goes along, or the amount of bleeding may be sufficiently small that no damage results. So cavernoma hemorrhages fall into this category of stroke. The term apoplexy was still in use up until about 1929, and stroke only began to be defined by the World Health Organization in the early 70s, and that definition has been refined a few times because the terminology continues to be a little confusing both for patients and doctors. And we have terms like mini stroke that enter. A mini stroke referring to is a transient ischemic attack, and this is an event where the insult on the brain cells is not reversible, It's self-limiting within 24 hours, but it may point to the risk of a stroke developing in the future, and therefore it's very important to anticipate and, if possible, commence a patient on measures to protect against stroke in the event of a TIA. With the advent of the aforementioned thrombectomy for ischemic stroke, um, we're being encouraged more and more to think of these as sort of brain attacks, to focus everyone's mind on the relative urgency. We know everyone understands that when you're having a heart attack, you go to the hospital quickly, and the sooner one can intervene to re-establish blood flow to the heart, the more you can protect of the muscle. The same is to an extent true with the brain. And it really only takes efforts to treat between 2 and 4 people with a stroke to get a significant benefit from thrombectomy. So it's very, very worthwhile. The thing about cavernomas, which has really led to a knotty question for neurosurgeons, is that they leak blood almost by definition. Um, they are characterized by at least the side products of blood cells staining the brain around them. The picture I'm showing you here is just a representation of a spinal cord cavernoma, made up of these different little chambers walled by immature, maldeveloped cells that at one point perhaps wanted to be blood vessels, but for reasons that we don't always understand went another way. It's connected to the rest of your body's circulation by a relatively low pressure system. And there are models that, in piglets, for example, who have been given genes that cause them to develop cavernomas, where when the piglet is born, the gene is present, but you do an MRI and there's no obvious cavernoma present. However, if you slice up the brain and look at it under a microscope, you can see these lesions already beginning to develop. And as blood leaches out and stains the brain around them, they develop this characteristic appearance on an MRI scan with, in this particular type of MRI scan, these bright areas within showing the caverns, and this dark ring around it is actually a protein iron complex we call hemosiderin, because iron's very toxic to the brain. And those of you whose mothers reminded them to eat more iron, it's good for your blood, will know that at the center of the hemoglobin molecule is an iron molecule. And when the hemoglobin molecule is released from a blood cell and finds itself alone in these tissues, the iron is left behind, and it's very toxic to the brain. So the body wants to wrap that in a protein to protect the brain from it, and it creates this appearance. The protein composite is called hemosiderin, and this dark ring, which is so characteristic of cavernomas, we see in completely asymptomatic cavernomas. So is it therefore correct to say that that cavernoma has hemorrhaged? Technically, blood has come out of it, but that does not necessarily mean it has caused any symptoms. And you will all have been shown many, many times, I'm sure, pictures of berries to remind you how they're supposed to resemble cavernomas. I've just chosen to show you from an operation on a brainstem cavernoma the resemblance in real life. And invite you just to regard the tissues around the cavernoma here in the brainstem. Take it from me that that should look lily white. But in fact it takes on this golden hue, which, as you can see, is far more widespread than the actual cavernoma is. There's not an overt hemorrhage or blood clot around this cavernoma, but it has been producing a lot of symptoms simply by the progressive effect of more and more iron being deposited in the brain stem. So there are more ways than simply destroying nerve cells that the egress of blood from a cavernoma can affect function, affect quality of life. But is it true to say that that is quite the same thing as a stroke? When we're worried about a bleeding stroke, our first port of call is usually a CT scan. And it's actually the anniversary of the first ever CT image being created at St George's Hospital last week. I think it's a 50-year anniversary. But the CT scan is actually an X-ray. And for those of you who are not familiar with looking at these, we're looking at a slice through someone's head here. And we're looking up from their feet. So over here is the left ear, over here is the right ear. These are the sinuses at the forehead. and the back of the head is here. There is, to the trained eye, something going on here, but there is no overt bleeding. Overt bleeding looks bright white on a CT scan, and it's easy to pick out. That's why CT scans are really useful when you want to decide if there's been some significant bleeding. But on the MRI, you can quite clearly see, this is what's called a T2 MRI. There are different sequences or TV channels, if you like, of MRIs that will emphasize different things you're interested in. But the MRI shows the characteristic appearance of the cavernoma at the center with the hemosiderin ring around it. But there hasn't been any acute hemorrhage. Contrast that to something like this. This is a patient who has bright white acute blood that has developed, but it has confined themselves within the lesion itself. So the blood hasn't left the cavernoma, but this kind of intralesional bleeding can also produce symptoms by a transient increase in the volume of the cavernoma that might irritate the brain and trigger something like a seizure. This is what we call extralesional bleeding. And here we have a large cavernoma on the CT scan here, but we can also appreciate this white shadow, the fact there are two layers representing different ages of blood that have come out in two fairly rapidly successive waves from this cavernoma, creating a lot of pressure around the brain. This is an overt brain hemorrhage brought about by a cavernoma. And on the MRI to the side, you can appreciate the very dramatic appearance and the effect that that's having on the brain, pushing it across to the other side. So the point in showing you that is to make crystal clear that these are not equivalent processes from my point of view. This will not always lead to the symptoms. This will inevitably lead to symptoms and often quite serious implications for somebody if it's not very promptly addressed, and sometimes even if it is. So simply to say that one has seen blood on a scan is not to say that an individual has suffered a stroke. But would that be enough for us to say, well, sure, we should therefore definitely treat a cavernoma if we see evidence of bleeding? As I said, that has been a really knotty question for neurosurgeons, because for years and years and years, we have tended to use a description of bleeding as justification to intervene and remove a cavernoma. But when you go back and really critically analyze that literature, you find that we're not always describing quite the same set of problems. And the difficulty that creates then is, how do we learn lessons if we're comparing apples with oranges? There has over recent years been lots of efforts to synthesize the different elements of the medical literature and see what lessons can be learned. And that confusing looking slide I've got up there at the moment could just be summarized as follows. If there's been bleeding from a cavernoma, then that does inform the risk that it will bleed in the future. But bleeding itself does not inevitably lead to disability. That is to some degree affected as well by where the cavernoma is located within the brain. The frequency of bleeding complications is also independently informed by the location within the brain as well, and we recognize the brainstem as being particularly associated with people presenting with symptoms, which then leads to a diagnosis of bleeding. The reason for that may be because there's so much more function gathered into that small area of the brainstem, which is at the center of the brain. It's the heart of what generates your heartbeat, your rhythm of breathing, and many, many other very important functions. A very tiny amount of bleeding there will cause symptoms, where a very tiny amount of bleeding elsewhere might not. Also independently predictive of future hemorrhage was a person coming, therefore, with symptoms such as a focal neurological deficit, a weak arm, a weak leg, a facial droop, a double vision, something like that. And we are interested as a profession in trying to make good decisions about treatment, because treatment carries risks. And one of the consequences of an operation on a person's brain, with the best intentions of the world, can be to destroy nerve cells irreversibly, which is a stroke. So we really do require evidence that if we're exposing somebody to that sort of risk, there is some real benefit in it for them at the end. And that's where we are with Cavernoma research at the moment, I would say. We have a lot of tools at our disposal, things that we can do, but we don't always know that we should do. And when somebody first presents with a symptomatic cavernoma, you may be looking at an individual who will never come back to your office for decades, or may remain entirely well for a very, very long time, who doesn't need to take those risks in the short term. Equally, you could be looking at somebody who will suffer a disability that in a very short period of time, you as a neurosurgeon might look back and think, perhaps I could have done something to influence that. And while, of course, that sort of progression in disability is tragic for the patient, I don't like it either. I got into this, and I think most of my colleagues got into this to help people. And the feeling that you could have done something, but you didn't know whether you should, is uncomfortable. So that brings me to the CARE study. The CARE study is ongoing in the UK. It's a pilot phase randomized trial. The thing about research is you have to make compromises, and not everybody can agree on every element of what goes into research. But I think this is a really important attempt to try and increase the amount of information we have to make good decisions about treating cavernomas. And a person with a cavernoma is eligible for the CARE trial if they've got symptoms caused by a definite brain cavernoma. If your doctor's not sure what you should have, then you can be randomized. Human beings being what they are, some of us are more certain about things than others. I would say to you, as somebody who considers himself well informed about brain cavernomas, there are regularly patients who I am uncertain about what the best way forward for them is, rather as I've just described. And I would like to have better quality evidence to guide me. You need to be able to make your own decisions to participate in the study, and you should have at least one brain cavernoma that has not been treated already with surgery. What will happen then is you'll be seen by your local research team, and in the UK, your local cavernoma Centre of Excellence at your neurosurgical unit should be able to advise you about the CARE study. It's not open in every centre, but there are at least a dozen centres open at present, I'm sure. If you agree to participate in the study, there's a 50% randomization between treatment and no treatment. The treatment will, to an effect, be influenced by what your clinician feels is best for you, and perhaps your own preferences as well. And then there'll be a 6-month review with the local team, and also 6-month contact with the central research team at Edinburgh University, after which the study will end. And it's in its pilot phase now. It's just gotten past the halfway mark in terms of recruitment, and hopes to gather enough to tell us what is feasible to recruit to a randomized controlled trial in the next few years for cavernoma treatment. And I commend it to you. Please reach out to whoever you feel might be appropriate for more information about it. You can take a picture of that QR code there, and it will take you to the trial website. And at that, I am going to stop and say I'm ready to take your questions.
Great. Thank you, Daniel. And just on CARE study, obviously you can contact us for information on there. That was a brilliant pitch for that, Daniel. So yeah, anybody's got any questions on that, just contact one of the team at Cork and we can tell you where to go from there. But I'll hand you over to David and Pat for questions.
Right.
It's quite a few.
Yeah, you start.
There were some questions sent in, and I'm going to start by reading those out. And then there's a lot of questions in the chat line, but people can also ask questions themselves. And the easiest way, or the best way to do that, is to put, there's a thing called reactions, which enables you to put a raised hand on your screen, or if you don't have a raised hand, unmute yourself and say question in a loud voice and we'll hear you. So the first one is, I think it's okay to, is named, it's from Tara Sexton. Tara, do you want to ask that or shall I ask it? Reading your thing out. I'll read it out. My name is Tara Sexton. I have 3 cavernomas, which I've lived with for a few years. At the moment, I'm suffering from really bad headaches. I had a bad knock to the head a few weeks back. I'm just wondering, how do I tell, or how will I know if I've got a bleed? I've been in touch with the hospital, but they aren't able to advise me. Thank you.
Okay. So, well, we've just heard about what exactly does one mean by a bleed. At the very least, it sounds like it would be, a small. If anything, it's more related chronologically to the trauma, isn't it? A bump on the head, and of course, people with cavernomas are not immune to other things that we're all exposed to. So you bump your head, you can get other kinds of brain injury from that as well, or simple minor superficial traumas too. So bumping the head itself is not particularly associated with cavernomas bleeding. If the reason you bumped your head was because you got a sudden headache and collapsed and bumped your head, that would be more suggestive that maybe there was an event involving the cavernoma. But the blow to the head itself is probably pretty unlikely to make the cavernoma change its behavior. In general, serious events inside the head don't tend to settle down on their own. They don't tend to respond to paracetamol. In saying that the hospital are unable to advise you, I'm not entirely certain what that would mean. I'm not sure whether they've done a scan or not, or whether they feel a scan is necessarily indicated. It may not be if you've recovered well and it was a transient event, because of course one doesn't want to be having radiation more often than one really wants to. And it's quite common when people have scans and perhaps they're interpreted by folks who don't have the complete clinical context or perhaps don't deal with cavernomas a lot. They're not infrequently referred to as brain hemorrhages. They're referred up to us and we say, no, that's not a brain hemorrhage, that's a cavernoma. And sometimes they look like that. So I don't know if that helps you at all. If in doubt, you should talk again to either your GP or your local emergency department.
Okay, the next question is actually written in, but it's also in the chat line. I would like to know if you think it's safe to have Botox done in my forehead for cosmetic reasons due to my wrinkles. I've had it done once, but I would like to have it done again soon, and also have it done around my eyes. Would you say this is safe with a cavernoma?
I don't think there's any reason it shouldn't be. I think it's fine.
I think, Pat, your question's been answered. Is that fair? You're muted. You're muted.
Yeah, thank you.
Yes, I think so. Someone asked it independent of me in the chat line, so I don't know if they feel satisfied. But Daniel, I asked, when does a cavernoma bleed become a cavernoma stroke? But I think you unpacked that brilliantly in your talk about, it's much more complicated than even that. And someone else asked that. If you have anything more to add to that, please do, but thank you.
Well, it gets still more difficult when the person asking the question about is it a stroke has their own agenda. So for example, some of you might have been faced with that question from your insurance companies or from mortgage lenders, things like that. And I will quite often be sent forms saying, has this person had a stroke? And then they will give me a definition of stroke, which is quite broad, and could be applied to the relatively small hemorrhage from a cavernoma from what an individual had completely recovered, but maybe had some non-specific residual symptoms. Now, the condition of this, of me saying yes or no to this being a stroke, might be whether this person receives an insurance payout. But once I label that individual as having suffered a stroke, I may be creating a situation that they then have to disclose to other providers or lenders or people who can influence their happiness further down the road. And neither does one want to be even subliminally conveying a message to folks very early on in their recovery that recovery is not possible. Because it takes quite a long time to know how one can recover from an event like a brain hemorrhage. And while it might be per se a stroke, it does not necessarily inevitably mean permanent disability and dependence on others for elements of care. So it is a more complex question than it first appears. And I don't think everybody has quite the same anticipated satisfactory answer.
Next question. Someone would be grateful for your take on pros and cons of gamma knife surgery.
So this is something we have spirited discussions about in the context of, for example, the CARE study. Gamma knife radiosurgery is a really useful tool that has been very successful at assisting with a particular type of vascular malformation in the brain over the years called arteriovenous malformations. I can understand how it works in arteriovenous malformations because it visits a physical injury on the blood vessels of the abnormality, and gradually they become scarred and shut down over 3 to 5 years. Now, it has also been used to treat cavernomas, and the difficulty with cavernomas is the natural history of cavernomas sometimes, and by natural history I mean what happens if you just do nothing. So if a cavernoma comes and it's symptomatic, it is possible that nothing else bad will happen for a very long time. I recently saw a gentleman, he might be on this call, who came to my clinic. He'd had a brainstem hemorrhage 40 years ago, and since then nothing else had happened. And there was no option to treat him. Now, it would be lovely to know in advance that that sort of thing is possible, but we don't at the moment. But the attraction of gamma knife treatment is to an extent that it's hands off. It doesn't require someone like me to make an incision in the patient and intrude into their brain. There's something very, very personal, I think, about the causing somebody disability with your own two hands, however careful and however well-intentioned one is. But I sometimes worry it gets a little bit easier the more remote you are from the patient. But the idea is to alter the physical makeup of the cavernoma with this high intensity radiation in such a way that it will bleed less in the future. Radiosurgery usually takes several years to have its maximal effect in the context of AVMs. Maybe that's not quite the same in cavernomas, but we don't know yet. And it really would take quite a long time of follow-up to be highly confident that it's making a difference. And I think the real experts in radiosurgery will tell you don't think for a moment it doesn't have side effects as well, because you will sometimes see on scans that there's a reaction in the brain around the treated lesion, in this case a cavernoma, a type of sunburn, if you like, a reaction to the radiation. In my practice, I've yet to see a cavernoma completely disappear following gamma knife treatment. I'm invited to believe that it's now going to behave differently than it did before, but I don't know that I have the evidence on the table at the moment that I'm highly confident of that. So my practice at the moment is I reserve it for situations where the cavernoma is clearly behaving badly. I'm worried about its effect on the patient, but I feel that the risks of surgery are so high that some alternative might be entertained, even if I'm not certain it's highly effective. I don't think it should be regarded as a panacea, and I think it needs to be rigorously studied.
Would it be fair to say that the CARE study might have some answer to that, because some people are randomized with gamma knife?
Yes and no. And this is a personal take. As I said, we have spirited discussions about this. The preference for everybody is on a spectrum. And if you take the average neurosurgeon like me, at one end of the spectrum, theoretically at least, is an individual who has no concerns for the complications that might be visited on the patient, and therefore everything is operable. However, at the other end of the spectrum, you theoretically have the individual who is unprepared to take any risk whatsoever, and therefore nothing is operable. And in the middle is the reality of surgery. So we are always accepting that there is some risk in what we do and balancing that against what we evaluate the benefits to be for the patient, rightly or wrongly. At the moment, I don't think there's consistency in what we term operable and inoperable, particularly in relation to brainstem cavernomas. And I think, some of your members will no doubt have experienced quite a variation in opinion. It's not because one individual there is right and one is necessarily wrong. It is more to do with the fact that we really haven't looked at this rigorously enough, or it hasn't been practical to do. Now we are randomizing to radiosurgery in the CARE study. When I'm speaking to patients about it, I make clear that I don't think they should just regard radiosurgery as equivalent to surgical removal for what I believe is an operable cavernoma, because I have a much larger evidence base, albeit some of it anecdotal based on people's experience, but large experience over long times, as well as my own, to tell me give me a sense of what's possible and what works. Whereas with radiosurgery, I'm dealing with much smaller numbers of people treated over much shorter periods and without the cavernoma disappearing. We're just invited to believe that it is now different. So I don't think we should be regarding them as equivalent treatments. I think if the CARE study came out and the treatment arm was predominantly radiosurgery as opposed to balance between the two, that might limit its usefulness. But that, in a way, is what's being explored in the pilot phase of the study, to see what the degree of equipoise among surgeons is in the country, and also where they sit between choosing surgery and choosing radiosurgery if they're going to give treatment.
Thank you. The next person asked says, I'd be interested in any insight into links between COVID and bleeds. And brackets, I had my first bleed 7 days after testing positive for COVID. So I'm always wondering whether it's related.
Yeah. So, as I said earlier, people who happen to have cavernomas are not immune to other things such as COVID. Wouldn't it be wonderful if you were? But so it is possible for two things to be unrelated, although chronologically close. There is, though, on the other hand, a plausible means by which a COVID infection might cause bleeding of various sorts in the brain. The best known and most discussed example being the microthrombosis that's been identified, complicating in particular severe COVID infections, but also microthrombosis, I should say, is blood clots forming in small veins and small capillaries at various places in the body, but sometimes in the veins of the brain. And you will probably all have seen news articles about cerebral venous thrombosis being a complication of COVID infection. Now, anything that predisposes to thrombosis carries with it a risk of that blood clot creating back pressure nearby and resulting in bleeding. And cavernomas are sometimes associated with things called developmental venous anomalies, which are functioning as part of the normal circulation of the brain. But if one of those was to thrombose adjacent to a cavernoma, the clinical picture may appear like a cavernoma hemorrhage. It's a very rare event in the big picture. And it's not clear that it has particular implications for prognosis with something like cavernoma at the moment. So we still don't know whether the era of COVID resulted in more hospital admissions with brain hemorrhages. Our initial sense is it probably hasn't, barring that blip with cortical venous thrombosis, although in absolute terms, that's still a very, very rare event. So it may be that they're linked. It may be that it was just written that the cavernoma was going to declare itself at that moment. I don't think we know right now.
Faris, you have your hand up. Would you like to ask your question?
Good morning, everyone. Good morning, Dr. Walsh. How are you?
Good morning.
How are you? This is Faris from Saudi Arabia. How are you doing?
Oh, wow. Okay, you're I hope you don't have a cavernoma. He's a neurosurgeon from Saudi Arabia.
No, I don't, but I'm really intrigued with your lecture. I love it. Especially, I'm in favor of the similarity that you pointed between neurovascular surgeon and a plumber, which I think is true. Very true. So, just a small question to you, if you don't mind, Dr. Walsh. The Cavernoma, as you beautifully illustrated, is a complex disease. It needs a lot of expertise, a lot of work to be done. My question is toward those people who are less fortunate and whom are not living in a place where they have access to high, high pinch, should I say, clinical care. Is King's or the other authorities in the world dealing with Cavernoma are doing anything trying to develop some sort of a connection or some sort of a pathway for those people who at least need the advice? I mean, it doesn't always need surgery, it doesn't always need treatment, but certainly it's always need advice. And this could change a patient from being worried, which could affect his life in general, to a patient who can function normal.
Yeah, that's a great point. And, in lots of ways, that's probably, the realization that we may not always need to intervene in a lot of cavernomas, or perhaps shouldn't. And the demonstration of that by reviewing the literature has probably done more for people in resource-constrained environments around the world than technological advances in the treatment of cavernomas ever would. With the way we can speak to each other around the world as we're doing right now, organizations like the Cavernoma Alliance and the Angioma Alliance do a great job of bringing people together around the world to share experience. And it's possible to disseminate that message that just because you have found something on a scan, it doesn't mean that your life is now necessarily curtailed or profoundly changed, and that you may have options other than a risky operation, including just living with the disease and managing expectations. And as you say, knowledge is power. I'm a big believer in talking therapy, although, as well as being a plumber. And I think educating people who have these conditions, making them expert patients themselves, and educating them about the gray areas that I don't understand, I strongly believe breeds confidence, and that they are on, once they embark on their path, they're on the right path, and then they know when to ask for help and also know how to interpret it. So I think that's a good point.
Very well said. Thank you very much, Dr. Walsh.
All right, thank you.
Next question. This is from somebody saying, I have numerous cavernoma. Unfortunately, over the last few years, I've developed vertigo and tinnitus that's steadily getting worse. Although after having both CT and MRI scans, my consultant seems to think it could be a microinfarct of my brain stem cavernoma. On a good note, there are no new signs of bleeding at all. However, I'm still declining. The question, is there anything I could do to arrest my situation?
So I'm not really going to be able to answer that in this setting. It's a really difficult question, and there are a number of ways that sort of progression can come about. As you say, one might be because of small strokes occurring in very vital parts of the brain, such as the brain stem. Another route that's less often recognized, but is something called siderosis. So if you remember the black ring around the cavernoma I described earlier, if somebody has multiple small hemorrhages from something over a long period of time, some of those blood products get into the fluid around the brain. The brain is normally making something called cerebrospinal fluid, and that circulates around the brain. And if there's small amounts of blood in it, that goes from looking like water or gin to looking rather yellow, a little bit golden colored, like the brain picture I showed you. And again, that's because of iron. And as I said, iron is toxic. And siderosis refers to a condition where that iron circulates and is laid in a very, very thin layer along the nerves that are coming out of the brainstem and along the surface of the brain. It's usually observed lining the back of the brain here, the cerebellum, the balance area. It often presents with things like hearing loss, dizziness, balance problems. So that's another possible way. Now, that can come about. It's unfortunately there aren't necessarily easy solutions short of if one can identify where the hemorrhage is coming from and take that out of the equation, that may reduce the likelihood of progression in the future. But of course, that may come with problems of its own, and it's not always pragmatic or practical. So it's a very complicated situation, and there are many ways it can come about. So it's a little hard to advise.
I've got several questions from one person who has a familial form with too many cavernomas to count. His brother has 3, one daughter has 3, the other daughter has numerous, and the niece has 6. Does this type of cavernoma tend to bleed more easily, more often?
Maybe is the answer. There are different gene mutations that result in familial cavernomas. And the best known of the 3 are called the CCM1, 2, and 3 genes. And there is some work which suggests there are differences in the likelihood of hemorrhage depending on the particular mutation that one has. I think CCM3 is the one that's been associated most frequently with hemorrhage. So whether that, though, depending on, when you've got multiple cavernomas in multiple locations, it simply may not be practical to get rid of them all. So until we have, and unless we have a systemic therapy that you can give a person to stabilize those cavernomas in some way, taking them out one by one like whack-a-mole is probably not the answer, is it? There are a number of agents under investigation at the moment. It's hard to know. We're probably years and years away from even if the trials are beneficial from really them coming on stream. But things like propranolol are being investigated as a means to stabilize cavernomas in those patients. There are superoxide radical scavengers being investigated. There are theories about the way they interact with other systems in the body, such as the gut, that might bring about, that might open routes to new therapies. But it's all very much on the bench at the moment, as opposed to in practical use, I'm afraid.
Some of those are in practical trials, aren't they? There are some who've got as far as phase 2, I think.
Yeah.
But that doesn't change your answer.
It doesn't really. There's the Treat CCM trial, which I think started recruiting in 2018, and I believe is going to report its pilot phase shortly. Now, I think it won't, it simply won't be powered to say propranolol definitely stabilizes and reduces the number of hemorrhages in a relatively small group of people for a small period of time, but it may open the door to further trials, larger scale international trials that might hope to answer that question. And of course, you don't want to just start giving people propranolol on a whim, because it has complications of its own. It's a safe drug. It's used for other things, but that doesn't mean it couldn't adversely affect an individual. There's another trial called Recursion that's open. There are a few around the world, but really the search for a systemic therapy for people with multiple familial cavernomas is probably the future for them, as opposed to individual technological means to address single cavernomas.
There are quite a lot more questions to ask. Are we going to be able to stay beyond 12? Because if not, would you be happy if I selected ones that I think are particularly new?
I'm at your disposal.
That's very kind of you.
I'll go all day if you want.
Thank you.
We'll carry on a little bit beyond 12 then. I'll keep asking. This is the same person who's described their family with familial cavernoma. Is the number of cavernomas across the family unusual?
No. Again, tends to be, that there would be multiple cavernomas if there's a genetic influence to it. The first sort of clues that there was such a thing as familial cavernomas, I think, involved families of Hispanic origin in the southern United States. So you do encounter families where there's a long history of these, and as I said, going back, if you've got long genealogies and you know what to look for, you see the term apoplexy, that might be pointing to cavernoma-related epilepsy or even strokes brought about.
His daughter, who has numerous cavernomas, is worried about her 2 children. Should they be tested?
This is always a really difficult question, I think. What I say to people is that the diagnosis of cavernomas in itself, the mere presence of the cavernomas, does not mean that you're not an ill person, you're not a well person. It's not clearly the case that your life will be shorter, less productive, or less enjoyable. What is one hoping to achieve in discovering the cavernomas? Merely knowing that they are there may produce something of a psychological burden. Some people have this wonderful ability to be told you've got a condition that could potentially hurt you, yet it has not so far. And they can say, that's fine. I'm going to put that at the back of my mind and I'm going to live a normal life and do the things I want to do. But there are other people who, when given that information, make changes to their lives and limit themselves, and no amount of reassurance can really prevent them from feeling that they've lost something. And in that case, what's really the problem? Is it the cavernoma, or is it the knowledge that it's there? So I think everyone is a little bit different. With children, if they are asymptomatic, I don't personally think there is evidence at the moment that the diagnosis of the cavernoma should lead to treatment such that it would be mandated, and therefore the option might be to wait until the child attains maturity and allow them to make that decision for themselves. But another perspective is, well, if there was a cavernoma there and it was treatable, perhaps you'd have an opportunity to fend off an event that might change their lives for the worse, and I absolutely would have to accept that. But we should recognize that in absolute terms, the risk of a first hemorrhage is sitting at something like 1 in 200 per year, and if it's a lobar cavernoma, for example, the likelihood of that translating to disability is low in absolute terms too. So is that worth the baggage that the diagnosis may come with? So I don't go and have scans without talking to an expert in either clinical genetics or cavernomas or both, is my advice. It's very easy to get an MRI these days. It's a little bit harder to live with what you find.
Thank you. This same person's neurosurgeon thinks he may have a slight buildup of fluid in the brain that is causing symptoms, maybe from persistent leaks. He's on a waiting list to see if a shunt would help. Do you think that a shunt might help?
I don't know, and would absolutely defer to the neurosurgeon who's looking at the scan. That would be a diagnosis you would make by looking at the imaging, sometimes by doing some other tests like measuring the pressure inside the head by one means or another. And it's a very clinical decision, so I couldn't comment.
I'm going to read another sort of case study, as it were, from somebody, and then there's several questions, and it's a sort of different level or different type. My son is currently 13 months old. At 8 months, suffered a stroke and a large intracerebral hemorrhage. Prior to this, he had no medical conditions. We were offered the watch and wait approach with a follow-up MRI 6 weeks post-hemorrhage. Unfortunately, during that time, his head had continued to bleed, and he had to have an emergency craniotomy to remove the blood and other tissues within the brain. Histology confirmed that the cause was a cavernoma in the occipital region. Surgery was successful and entire cavernoma believed to be removed. Unfortunately, only this week, his seizures returned and a CT scan showed a smaller bleed and what they believe to be more cavernoma. Questions. Have you ever experienced such a large bleed in such a young baby?
Unfortunately, yes. It is in relative terms very, very rare. There is a point of view that there are certain types of cavernomas. We would call these phenotypes. So there is something in the genetic makeup of the individual cavernoma that makes it more aggressive, and those seem to be diagnosed more frequently in children. It's not the story for everybody with a cavernoma, as you will know within this group, but it does, straight off very, very early in life, those are clearly troublesome lesions. I think there is likely to be an underlying genetic mutation, and know that will be looked for. There are some rare conditions linked to that I think make that worthwhile investigating further, just in case there are other vascular lesions as well within the nervous system. But no doubt the team looking after them are already thinking along those lines, I suspect. But it's a very sad story, and it's deeply, deeply unfair.
Have you ever experienced post-operatively another bleed to happen so soon in such a young baby?
Personally, no, but it's a rare event. I mean, the reality is, I'm not completely clear whether we're talking about bleeding into the same cavity or whether we're talking about bleeding in a different location in the brain.
It's, sorry to interrupt, it's into the CT shows it's into the same cavity, so the space within his brain has obviously started to fill with the fluid and obviously other liquid matter, and to the bottom of that cavity close to where the incision was, that's where it is. I think they believe it's sort of residual cavernoma that started perhaps to grow back. We are just waiting for the MRI, which fingers crossed is on Monday.
Yeah, well, that may be exactly what's going on. There may still be something there that requires addressing. And the reality is, with any vascular lesion in the brain, if you're trying to remove it shortly after a large hemorrhage, it's harder to see the wood for the trees. It's easier for little bits of the cavernoma to hide. I didn't show a lot of pictures here, but when we show those berry pictures, I show my residents that when you empty those berries, the wall of the cavernoma is transparent. The little cavern looks like a little glass bubble. So you imagine a completely transparent piece of tissue applied to the surface of the brain, which is already red and gold and deeply stained with blood. It's very, very easy to miss bits that can grow back. So I think it sounds like the right things are being done, but I'm sure that they may consider other treatments with that story down the road if necessary.
Have you known a cavernoma grow back? This is from the same person who's been asking these questions, or represent within a short time of the final clinic, all clear?
Yes, I have, and I think this happens more often than we admit. And I think the reason is what I just described about the nature of the caverns themselves. It is entirely possible to think you've completely removed a cavernoma, but leave some cells applied that grow back. And there was what I think is a really good institutional series from Italy a couple of years ago that really were completely honest about this. And I think the rate of recurrence was about 10 to 15% after what was believed to be complete cavernoma removal. That feels right to me. I always consent patients for what I'm talking about here. The possibility that I might think I've completely removed it, the scan might be reassuring, but that it could grow back. And the good news from their study was that even in those patients, the rate of bleeding seemed to be affected by even the partial removal of the cavernoma. So the rebleeding rate seems to have substantially reduced over the initial presentation rate. Now, there are all sorts of limitations to that conclusion, but it was quite a big series and it was very honest, and I thought it's probably on the right track. So I think this is very much something that can happen. We have to hold our hands up to it. and manage it as it comes along.
Eleanor, do you want to, your hand is up?
Yeah, sorry, I just popped it up because we're short of time because we're just in the hospital at the minute. No, that's really, really helpful. Thank you so much for that that information. Just one quick question before I let you move on to somebody else.
Mm-hmm.
I mean, I don't know what the MRI is obviously going to show yet. Would you recommend or would you ever suggest going back in via the same incision to remove that smaller piece of cavernoma that is potentially left, or is it because it's a lot smaller than obviously what the original one was? Is it more of a watch and wait approach that you would suggest?
That's a decision to be made by the doctor on the scene, but it's on the table, I'm sure. Again, even going back in to remove what you can see isn't a complete guarantee against recurrence in the future. We'd have to acknowledge that. But in the face of something that was behaving aggressively very early in life, it might well be something to consider. Now, you would also have to take account of the physical condition of your potential patient at that stage. Do they need a little bit more time to recover and so on? But there are considerations like if there's a cavity there still that facilitates access to the cavernoma, there might be a window of opportunity to do an operation that would close later on as things heal up. So there's a lot of things to consider, and it's I wouldn't presume to second guess the folks on the scene who are no doubt know their business and will guide you through this. But it's a horrible situation.
Dieter?
Thank you so much.
No.
Dieter Purcell? Your hand's up and you're muted.
Hello, hi. So sorry about it. I'm in the car driving. Listening to this. Can you hear me now?
Yes.
Yeah, Oberon. Okay. It's like silly question as for the previous one, but might be important for parents with children. My son, 14, now has cavernoma diagnosed about 3 years ago due to tonic-clonic seizures at night. So we don't really know if the seizures come when the cavernoma is bleeding or if it's because of the scarring. But the reason why I wanted to ask, a year ago he went to amusement park, and as soon as he went on the first massive roller coaster, had a massive headache, started vomiting, didn't want to go for anything else, and then 2 days later had another seizure. And know from my research, Google, it doesn't seem to be related, but is there any indication that perhaps roller coaster rides with massive G-force will not be recommended for people with cavernomas? Thank you.
Thanks for the question. I don't think there's any strong evidence to link them. The model I usually refer to when talking about limiting physical activity, a lot of people come to me having been told, okay, don't lift anything heavy. What's heavy? That's different things to different people. What precisely do we mean when we say that? And we can, as doctors, we can inadvertently affect people's quality of life quite easily by wrapping them in cotton wool when we don't have evidence to really say we're making a difference. You can give birth to a baby with a cavernoma without any compelling evidence that it will increase the risk of the cavernoma bleeding. That suggests to me that the tolerances are pretty well developed, and therefore there's probably not a lot of reason to limit people from normal physical exertion. You can be taking blood thinning medications, and there's no real evidence that increases the risk cavernomas will bleed. In fact, paradoxically, it might even reduce it in certain circumstances. So I think it's more complex than any sort of simple trauma being visited on the Cavernoma. That may have been a coincidence. It may not. I mean, inevitably he will link the two events in his mind, and that may affect how he wants to go on these rides in the future. But I don't think one could say it was causative.
If a cavernoma bleeds outside itself, do we always refer to it as a hemorrhagic stroke?
Good question. And yes, I think that would be, in my mind, that is certainly a hemorrhage. A hemorrhagic stroke means that it has irreversibly damaged brain cells. And if it's outside the cavernoma, it almost certainly has. Now, whether that has translated into disability or not depends on where it is exactly and the size of the hemorrhage. But it is a hemorrhagic stroke. And that's the sort of the insurance company type question. You can have a person who's gone home, gone back to work, living a normal life, but then labelled as having had a stroke on the basis that they've had an external hemorrhage. And technically it may be true, but it may
že
be
někdy
something
to lidi
different.
doporučujou, ale že to není, že třeba tam žádná evidence není.
I missed that. Was that a question or was that an interruption? I'm going to assume it was an interruption. Forgive me.
No worries.
I previously had a course of radiotherapy, 30 times high dose. This was to treat a brain tumour and thought to be the cause of my cavernoma. I have 4 in different parts of my brain. Would this previous exposure to radiotherapy preclude use of gamma ray to treat my cavernoma?
Yes, thanks for bringing that up. It's I didn't mention that actually radiation can cause cavernomas as well. Now there's a distinction between radiotherapy and radiosurgery. The goal of radiosurgery, which is what gamma knife, cyberknife, these things are, is to physically destroy a small lesion. At least in theory. So if you're treating a small intrinsic brain tumor with radiosurgery, you're giving multiple intersecting beams of radiation, which on their own, as they pass through the tissues of the body, aren't strong enough to do a lot of harm. But where they intersect, they have a very large additive effect. A lot of energy is delivered to that small area, and that looks to physically destroy the cells. And that's distinct from radiotherapy, which when being used to treat cancers that are widespread throughout the body or the brain, are looking to arrest these cells from growing. Not necessarily wipe them out, vaporize them, but give enough radiation over a wide enough area that it stops the cells dividing. So they're two different things, and it's probably the radiotherapy that is most associated with the development of cavernomas subsequently, because of the effect it has on the genetic makeup of the cells. Whereas, at least in theory, radiosurgery would be aimed at physically destroying the cells, and so if the cells were gone, they couldn't then turn into something else.
Joe has asked, it's now 12:15, has asked whether we could go on until 12:30, but call a halt there. Is that okay, Daniel?
That's fine.
And so we're going to do that. If people have to leave, I'm sorry. What are the implications of a DVA with a cavernoma?
The most important implication is that the DVA is recognized as being part of the normal brain circulation. So if we are doing surgery on that cavernoma, we will try extremely hard not to injure the DVA. And equally, I suppose, if gamma knife were being used, one would not want to include the DVA in the field of treatment. So the DVA has a job to do on its own, apart from the cavernoma, and should be preserved.
My cavernoma bled and stopped. Now I feel scared to travel by plane. Do you think the change in air pressure in the cabin might affect or rupture, or is that just a myth?
It's a myth.
Thank you.
This has been doing the rounds for many years, particularly in relation to brain aneurysms and other kinds of brain hemorrhage. But a colleague of mine in Germany, Nita Ettemann, did some work last year to synthesize all the robust scientific data on it, and the result was that there was no evidence that the small pressure change associated with air travel is going to cause a aneurysm or any other vascular lesion in the brain to bleed.
My son had a bleed from a cavernoma in 2017. That's now 5 years ago. Are the chances of another bleed decreasing as the years go by?
Yes. So the risk of a first hemorrhage starts to drop back towards the baseline it was before after about 2 years, from what we understand. So by the time you get to 2 years, if you haven't had another hemorrhage, you're probably back to your baseline risk, which, if it's a lobar cavernoma, could be as low as 1 in 200 per year. Now, obviously, these statistics are population statistics, and I don't want everybody to think you can just generalize these to the individual. But that's the snapshot. So yeah, as the longer it goes on, the less likely that there will be an event.
I discovered I had a cavernoma around 4 years ago, an incidental one. Apart from ongoing headaches, I had no symptoms. I've had 3 MRI scans to date, and they've shown no real change. My cavernoma is in the temporal lobe. How frequently should I have the cavernoma checked with MRI? I've been told there's no possibility of surgery.
Okay. Well, I generally don't routinely scan cavernomas if I'm confident that A, they're a cavernoma, and B, the patient is well. Because cavernomas will change shape a little bit, they may change size a little bit, but if those changes are not producing symptoms, then they don't, they're not predictive of how the cavernoma is going to behave in the future. Now, there's a little bit of discussion around very large cavernomas in that regard, but in general, we don't have evidence that you need to be routinely scanned or that in any way helps prevent strokes in cavernomas. So my usual practice is to say, have imaging if you have symptoms that you think might be attributable to the cavernoma.
Is there more advice available to people to assist with the psychological rather than physical issues of having a symptomatic cavernoma?
Great question. And I think organizations like yours really are doing most of the heavy lifting on this sort of thing. So you have, broadly speaking, you've got 2 kinds of help. You've got the healthcare model where, psychological support services and so on, that you can access through your GP if you go and talk to your GP about these issues or talk to your specialist about these issues. As I said, a lot of it is around understanding the condition, the limitations of our understanding of the conditions, and how the future is likely to play out. And then there's also peer-to-peer support. So there is the interaction you get with the other members of a group like this. But you do have to recognize and remember, and we always have to emphasize, that when you're talking to others affected by the disease, their version of the disease is not necessarily your version of the disease. Their experience may not be your experience. Some people will be mildly affected, other people very badly affected. And so long as one bears that in mind, peer-to-peer support, I think, is enormously valuable, particularly with the day-to-day practical stuff that extreme plumbers like me simply are useless at advising about, talking to the bank manager or accessing social services and so on. So with most things in our healthcare system, we would like to have more available in terms of psychosocial support. But I think if you're being affected by some of the psychological downsides of having a disease that could potentially hurt you in the future, for example, or the consequences of what it's already done, start by talking to your GP and saying, I'd like this sort of help. Can you give it to me, please? And I think you will find nearly always they will be very, very understanding and put you in touch with the agencies you need to contact.
What are your thoughts on emulsifiers and vitamin D?
I don't really have any. I'm not aware of any robust evidence to suggest that they should be used.
I think the question with emulsifiers is whether they should not be used. This is about processed foods and is based on the evidence on what am I after saying? I'm losing my thoughts.
The lipopolysaccharide and
Thank you.
isn't it? Yeah. There's quite a lot to unpack here. The short answer is what I said. There's no strong evidence at the moment in humans that they should or shouldn't be used. The most of the evidence, if I understand it correctly, relates to CCM3 familial cavernoma sufferers. People who have that mutation have that gene mutation also is, or that gene is normally required to produce mucus in the gut that plays a role in bacterial translocation, which means normal gut bacteria moving from the gut into the bloodstream. That then has some, there's some work that suggests that may play a role in the way cavernomas form. That's very much a research question at the minute, and I would certainly not be making practical decisions about diet or dietary supplements based on what is currently understood, unless you are a mouse.
Thank you. If someone keeps recovering from recurring bleeds, would you just recommend the wait and see approach because they do keep fully recovering, especially if the cavernoma is in a difficult part of the brain, for example, the cerebellum and peduncle?
It's different for everybody. One individual might be psychologically well able to tolerate that sort of approach, and it might be right for them. There are other people that sort of approach might be just too difficult, and their the balance of risk to benefit for them might be quite different, and the level of risk they might be willing to tolerate is different to the person who would rather avoid surgery or any other intervention at all costs. So I think that very much comes down to on a case-by-case basis what we call a shared decision. Your doctor educates you about the grey areas here, and for me all options would be on the table, and I'd be listening very hard to what the patient's fears, concerns and preferences were.
Would you advise them to go on the care study?
I would. Yeah, I would certainly bring it up at the moment.
Michelle, you've got your hand up.
Yes, hello, sorry. I had a question in the chat. I was told I had a stroke last July. The only reason I knew that was because I went to the eye hospital because I'd lost vision in my left eye. Went to the eye hospital, they sent me for a scan and said I'd had a stroke. That was the only symptom that I had at the time. 2 weeks later at work, started to feel unwell and was taken to hospital with seizures. Lost a whole week, don't remember anything about the first week in hospital. Was then told I had something, if any of you heard of, called Miller-Fisher syndrome, and was given levetiracetam for the seizures. In December at Christmas, I had a second bleed and was then told I had a possible cavernoma. I had an appointment with a neurosurgeon this week who says they're still not sure if I have a cavernoma or not, and they're still not sure what caused the bleed. I took a fall in the summer and I've had nothing since then but aches and pains in my arms and legs, burning sensations, dizzy spells, being unbalanced. So I'm now waiting for an appointment for another MRI scan. I'm quite confused as to what have caused all these issues because each consultant, whether the stroke clinic, the neurosurgeon or the neurology department for the Miller-Fisher keeps saying it's not them, it's the other.
Mm-hmm. Thanks for the question, and I totally hear you. You're at a very difficult stage where you really haven't got your diagnosis yet. You're in the process of working out, and I'm afraid, unfortunately, it does sometimes require a lead time to really understand what's going on. We have a philosophical precept in medicine called Occam's razor that says that usually the explanation there's a single explanation for multiple symptoms, and the simplest explanation is usually the right one. Now, there's exceptions to that rule, but when you start seeing different specialists, each specialist is being asked a particular question, which in your case will be different with the Miller-Fisher syndrome, which is a paralysis of some of the muscles that move the eyes, the doctors looking at that will be answering particular questions about that, whereas the doctor is being asked, could this bleeding be a cavernoma or the stroke be a cavernoma, may be facing scans at the moment that are still evolving. So in the early days after a brain hemorrhage is like a bruise anywhere else in your body. It evolves. If you break your wrist, it will swell up, then it will turn red, then it will turn black and blue over a few weeks and gradually go back to normal. And the same process will go on in the brain, such that you may not be able to see whether there is a underlying abnormality of any sort beneath blood until the blood dissolves away. So you might be at that stage of the imaging as well, where they need the imaging to evolve a little bit in order to fully understand what might have caused this. And we have a thing called differential diagnosis, where we have a list of things, a menu that it might be, and that list gets shorter and shorter as we get more and more evidence. So I suspect you're early in the evolution of your imaging, and there's more to learn.
Okay, thank you.
Catherine, you asked two questions in the thing, and I wasn't really ignoring them. Have you had both of them answered?
No, I haven't had my questions answered. I'd appreciate to ask them now, if that's okay, quickly. My daughter has two cavernomas, one in the right side of her brain and one in the brainstem. They're quite large, like 3 centimeters, almost 4 centimeters. I recognize that brainstem cavernomas are specialist side of cavernoma research. I wanted to know the pros and cons of surgery on a brainstem cavernoma and the risks and likelihoods of bleeding in the future of brainstem cavernomas.
Yeah. So, I think most of us would agree that brainstem cavernomas behave less well than other cavernomas, but perhaps the exception of the spinal cord. So they are known to bleed more frequently, and the volume and amount of bleeding that can lead to really serious disability may be less than in cavernomas that are located in what we call the cerebral hemispheres. You will, I suspect from your research, realize that there is a wide range of surgical opinions on the advisability or otherwise of operating on a brainstem cavernoma, ranging from you should never do it, it's always dangerous, through to it's very low risk and should be done all the time. There's that spectrum I'm talking about, and in the middle is where most people are. So when somebody comes along with a brainstem cavernoma, the way I look at it is, we have to start by having a serious talk about what we expect to happen in the future, and everyone has to understand that without a crystal ball, we don't know for sure this thing is going to harm you. We may have clues, and it's definitely on the table, but we don't know for certain it's going to happen. The next thing, from a technical point of view, I'm looking at where the brainstem cavernoma reaches on the surface of the brainstem. If it has a peel representation, which means it comes to the surface of the brainstem, then that is going to afford more opportunity than a cavernoma that's located deep within the brainstem and surrounded by functioning brainstem. There are routes one can take to cavernomas deeper within the brainstem that require quite a sophisticated understanding of the anatomy, but there's a term that is in use which I dislike, but I'm going to use it, called safe entry zones to the brainstem. Personally, I don't think there is any such thing as a safe entry zone to the brainstem, but there are anatomical approaches that can mitigate the level of injury that one's going to visit. And the man who taught me to do brainstem cavernoma surgery told me something that I still quote back to patients today. And basically, you say to your patient, the operation I'm going to do is going to give you the effects of the next brainstem hemorrhage, and then hopefully no more. And I think that's a very sensible rule of thumb. It's not an exact prediction, it's not an exact science, but I think that, I generally prepare people who are going to have brainstem surgery to face some setbacks and challenges afterwards, often hoping that they will recover in time as they would have from a hemorrhage, but hopefully minus the cavernoma at the end of it.
Can we just do one more question and call it a day, I fear? And I hope you haven't answered this already. Can having a craniotomy to remove a tumour cause a cavernoma? I also have a VP shunt. Can this have any cause of it?
I don't think so. I'm not aware of any definite association. If you had radiation subsequently for the tumor, which is often the case within certain types of tumor that are operated on, that might have had a role to play in the cavernoma developing down the road. But otherwise, I don't think the craniotomy itself is likely to cause it. What a craniotomy can do, or indeed a brain injury of any sort, can create a little bruise in the brain that can resemble a cavernoma on an MRI and be very difficult to distinguish from it. So there are situations where we see abnormalities within the brain that are made up largely of iron, that might reflect bleeding or bruising that's happened before. And we might say that it could be a cavernoma, but we can't be certain without actually taking it out and looking at it under a microscope.
Well, there was one question left. Am I allowed to ask it?
Yes, go ahead.
Thank you very much. I've been diagnosed with multiple brain angiomas and microangiomas last week. Is there a possibility that these will cause development of cavernomas in the future?
So this depends on what exactly you mean by angiomas and microangiomas. This is again a confusing term that's applied to a range of different pathologies, sometimes used to describe capillary hemangiomas, what we know as cavernomas, but also sometimes used to describe different types of vascular malformation within the brain. So it's a little difficult to answer without knowing precisely what we're talking about. There are benign entities such as things called telangiectasia, which are on the spectrum of vascular abnormalities as well, but they're very benign and are often incidentally found, and to my knowledge, not associated with the development of cavernomas subsequently, although they can sometimes be mistaken for cavernomas.
I'll just read out the last thing that appears in the chat before I pass back to Joe. It is, thank you so much. And then in large capitals, absolutely brilliant session. Thank you. And there are others that convey the same sort of concept but without the capitals. Caroline, I've missed you out. I think.
Thank you so much, Daniel. That was one more.
No, well, there is.
Wonderful. Thank you very much indeed, Daniel. Wonderful, easy to understand, and very interesting. Thank you.
You're very welcome.
I think the person who feels we haven't asked their questions, maybe they could write them into you, Joe, and we'll take it from there.
Yeah, absolutely. I'll pop my email on the bottom. Yeah, thank you so much, Daniel. That was a brilliant talk. Sorry we've kept you longer, but we appreciate you answering everybody's questions. I think everyone found that really interesting.
Thanks for your time on a Saturday, Daniel. That was really
absolutely brilliant.
Have enough to do without.
Well, thank you for all your hard work you do for our patients. We appreciate that as well.
Yeah.
Hard work. Gosh.